And then COG has taken up huge interest in LCH and histiocytosis. So Children's Oncology Group is the large group that tackles most pediatric cancers and has the really, really big studies. And so for the last 2 or 3 years, I've been working with the lymphoma group to try to get a concept through for LCH. And it made it all the way to the top of the NIH where they have this sort of final step. And it was the best rejection I ever had because it came back and they said, we believe LCH belongs in COG, which was something they weren't saying 3 or 4 years ago. Said, but the study wasn't ambitious enough. Come back with something bigger. So working on it. Okay. All right, so that's sort of the big picture. And then I thought maybe I'd kind of go through just a couple slides to talk about, well, what are these eureka moments? So Ken, I guess, was passing along this advice to me that he didn't care what I did so long as he hears eureka from the lab every once in a while. And I think that came from one of your previous mentors, right?
Yeah, it came from Dr. Fernbach, who started our
right. So we're trying to have as few of these light bulbs as possible and as many of these. So let me, not everything's a hit, but I think we have had a lot of big discoveries. And I thought we'd maybe just talk about some observations and how these observations have impacted both our group as well as how we think about histio. And if I start talking too long, you can shut me down. So, all right. So one of the first things that Ken and I did together was looking at, and what's truly ironic is this is the least scientific study I've ever done, and it's probably had the most impact and certainly has the most citations of anything we've ever done. I think it has well over 250, 300 citations. So I was a first-year fellow working with Ken. We were in the ICU, and there was a little girl who, had Epstein-Barr virus, parvovirus. She was, got renal failure, respiratory failure, and this is over a period of about a week. She was deteriorating, and it looked like she was, on her way to dying. And Ken was saying, well, we need to give chemotherapy to this patient. We need to give etoposide. This is HLH. And the ICU had a reasonable alternative view saying, well, why would you give chemotherapy to a patient this sick? It will just, it will knock out whatever immune function they have. And that's always the difficulty in using etoposide or trying to use even any kind of extreme immune suppression in kids with HLH. And Ken just said, well, if it's a ferritin over 10,000, it's got to be HLH. It can't be anything else. And so after we walked out of the room, and I said, well, how can you say that? There's absolutely no data. And so we sort of had a gentleman's bet. So I went back and looked at the 2 years of charts of every ferritin level taken at Texas Children's over 500, and said, well, what are the different conditions, and how does this kind of play out? And in fact, so this number one here is HLH, and this one was kids with unknown diagnosis, probably many of whom actually had HLH, and way down here is sepsis. And so, we put that observation out there that, elevated ferritin, really highly elevated ferritin, probably is a very reasonable screening tool to ask the question, if someone has extreme inflammation, what we say is that doesn't mean don't get the bone marrow transplants set up immediately, but at least think about HLH and do the diagnostic workup. And I think that as a screening tool it's an imperfect biomarker, but it's led to a lot of conversation and led to a lot of papers recently about how does this work in adults, what biomarker should we use in adults, and it's just, I think it was a gentleman's bet that led to a lot of conversation, and Ken won that one. So. All right. So I think that the next kind of big eureka moment probably the greatest eureka moment in our lab so far was when we were working on trying to figure out what this BRAF V600E phenomenon meant. So in 2010 in LCH, the BRAF V600E mutation was discovered in a cohort of patients with LCH from Barrett-Rollins group at Harvard. They had this really cool new technology where they could do this in paraffin samples. And so we had, one of the benefits of having all these samples in our freezers, I could say, well, if we look at 100 patients, how many have this mutation? Is this real? 'Cause it was using kind of a new technology, and I think people believed it, but it's interesting now. It's sort of assumed this is true, but it was such a paradigm shift. I think understanding how BRAF V600E fit into LCH didn't make a lot of sense at the time. But anyway, we found that 64% of our patients had the mutation in their lesions, which kind of supported pretty much exactly what he found. But then I said, I wonder if we can find this in the blood of patients with LCH. And so I had Karen Lim, who's my lab tech at the time, now she's a grad student, do some blood tests. And she'd find it in one sample and then not find it in another, and then find it in another sample and not find it in another. And I remember saying, Karen, you have to quit contaminating your samples. You have to do this correctly. And but she's actually never makes mistakes in the lab, so I thought I should take this seriously. But when we pulled back and looked, we saw, well, clinically it depends what the patient's like, whether or not we see circulating cells that carry the mutation. So kids with really low-level disease, only a single lesion, you never see circulating cells, at least in this cohort. And with non-risk, meaning it's not in their liver, spleen, or bone marrow, we almost never saw circulating cells, only in 13% of the cases. But in all of the kids with clinical high-risk disease, we saw these circulating cells. And that really led us to sort of conceptualize, maybe LCH doesn't in fact come from epidermal Langerhans cells. It's not just sort of the same model that you would think about with colon cancer, where you sprout from one polyp that kind of overwhelms the body. But maybe these are sort of different developmental processes that, how can the same mutation have such a huge difference in phenotype? And so that kind of leads us to this new model, which I still believe. I think we still have some work to prove this is completely true. But what we hypothesize is that if there's a mutation in the early precursor, this can go to basically every organ in the body and create this sort of high risk version of LCH. But if you have one of these precursors that's really committed to just being in the bone, or just being in the skin, or just being in the lungs, and that's the one that gets the mutation, maybe that's the sort of multi-system low risk. And what's interesting is, unlike other diseases, at least I can't think of an example where someone's had just bone disease, then when they relapse, they would get it in the lungs or get it in the bone marrow. It seems to almost always stick to the real estate that it's assigned to begin with, which is really bizarre, because that doesn't happen in any other cancer-like disease we look at. And then the low-risk single lesion could be just this one sort of guard that's manning only one little part of the real estate, and when that guy gets the mutation, it leads to this single lesion that maybe doesn't have the potential to differentiate, and you almost never see relapses in single lesion, and that kind of fits that story. And then, as Ken mentioned, we looked a little further into some specific types of disease. So we looked at skin, and this kind of again came from a clinical pattern where we'd get calls from these dermatologists that said we did a biopsy, it was LCH, but it's skin only. And we'd say, well, how do you know it's skin only? And so we want to see them anyway. Please refer them to us. And what we found was that about half the patients that were assumed to have only skin disease actually had disease somewhere else if you looked for it. And when we looked in the circulating cells, we found that these kids with skin plus multisystem, we could find circulating cells where we never could if it truly was skin limited, or we almost never could. And that also these kids with skin limited disease almost never had a problem after their initial disease presented, where relapse was much more common if it started somewhere else. So, next slide. So what this could represent is that these skin diseases could come from when we're all in fetal development, our skin is seeded with Langerhans cell precursors from the yolk sac. And it's possible that if one of these precursors is the one that's mutated, as soon as you switch from that fetal circulation to bone marrow circulation, these guys don't have another reservoir to draw from. So once those either spontaneously disappear or respond to chemo, they could be gone. Where if you have one of these guys gets mutated, then it could still go to the skin, bone marrow, bones, for example, and these would be harder to get rid of. So again, it fits. I wouldn't say it's definitive proof, but it's sort of a new concept of how to think of this disease. How can one mutation lead to all these different expressions? Okay, next slide. And then, as Ken mentioned, we're looking for alternative therapies. So one of the other things we tried in lab is, or not lab, but in our clinic, a bunch of kids who were getting pituitary disease, we started treating with cytarabine as frontline therapy, because Ken had some evidence that cytarabine seemed to have an effect in some kids with neurodegenerative disease. So the idea was, well, let's try it as upfront for these patients to maybe prevent neurodegenerative disease. And we found that at 1 year, we had 100% survival and 93% progression-free survival, meaning the relapse rate was way, way lower than on vinblastine and prednisone for an arguably small cohort of patients, 16. But that's what led to that the LCH reason protocol that I was talking about. Next slide. And then taking advantage of the volume that we have, we were able to test some other therapies. So Carlos Rodriguez Galindo had tested two or three patients. I think one of them was at Stanford with clofarabine, and found some success, and it makes sense. Clofarabine's in the same family as cytarabine and cladribine. For some reason, we find clofarabine is particularly effective. We don't really know why. But in patients who were multiply relapsed, who had failed multiple other salvage attempts with this therapy that can be given outpatient in most cases, as opposed to the huge AML-like chemotherapy that requires inpatient admission and is associated with huge treatment-related mortality. This is very good overall survival and progression-free survival for a very high-risk group of patients. And so this is now being tested in the LCH-CLO study. And so this will be another, I think, 60 to 80 patients that should really definitively tell us how clofarabine performs and what the toxicity associated with it is. Next slide.
When do you think you'll have news on that one?
It's just opening, so it'll probably take a couple of years. All right, so I talked a little bit about the differentiation of LCH and, well, where does the mutation come from? And I talked a lot about BRAF V600E. So one issue is, okay, well, if BRAF V600E is half the patients, what's going on with the other half? And so luckily, a friend of mine from med school, actually, Will Parsons, is one of the leading cancer geneticists in the country, and his office is just down the hall from mine, and he got badgered about me talking about LCH all the time, so he sort of snuck LCH in the front of the queue for some of his projects, and we really looked with the highest quality kind of methods at whole exome sequencing on a bunch of patients. We took 20 patients we knew had BRAF V600E and 20 patients we didn't know what they had. And just as a positive control, we were able to identify BRAF V600 in all the cases we knew by quantitative PCR. But what was surprising is we found recurrent mutations in this gene MAP2K1. And if you look at the RAS signaling pathway, so basically the way this works is every cell has these sort of receptors, and when these receptors get tickled, they then will kind of send a signal down to tell the nucleus, you need to shut down because there's no food, or there's an infection, so you better have a certain response. So anyway, in this pathway, it's RAS, RAF, MEK, ERK. MAP2K1 encodes MEK, and so it's down this very sort of straightforward canonical pathway that we found recurrent mutations in MAP2K1. And interestingly, we found a mutation in ARAF, and we found a mutation in ERBB3. And the story is kind of everyone has basically one mutation, and it's still not clear what's missing sort of in these patients who don't have MAP2K1, but what this led us to believe is, okay, that at least this suggests that there's probably a problem somewhere in this pathway in every patient, or at least in the majority of patients, and there's probably not an alternative cause of LCH. Next slide. Which led us to look even closer at that group of patients that we didn't know what was happening, so we used some even more sort of kind of precise methods. And what we've found is that in one patient, we found this BRAF fusion, and that's sort of a phenomenon that's been observed in a lot of brain tumors and other diseases. That another way that BRAF can be activated is it sort of pairs, the gene gets kind of cut and spliced together with another gene, and so this FAM73A in this particular patient is driving expression of BRAF at a higher level than it's supposed to be expressed. But then interestingly, we also found in 6% of the patients, there's this little deletion that arises, and it's not easy to find these indels because a lot of software programs will kind of read over them. But we just, as we look more closely, we find 6% of the patients have this deletion, and what that does is it causes the molecule to kind of fold over and be activated when it's not supposed to be activated. So now really we're down to sort of 11% of our patients. We don't know what's going on. But I mean, the story is getting filled in. And one question is not only what happens when the gene's activated at different stages of development, but is there differences in how MAP2K works versus BRAF V600E? And can we predict outcomes based on these different mutations?
And all that's happening off of tumor blocks?
Yeah.
Not circulating.
This is all tumor blocks. Then we can go to circulating and say, so if we find a MAP2K1, we can then look in the blood and say, do we find this mutation or not? The problem is that circulating is at the level of like 0.02% of the cells. It's so low that it's kind of almost where sequencing isn't that reliable. We're kind of working on that. All right, and so I think with all this progress, this is sort of an ironic story, but I think it tells you about we have to keep thinking about things. And so this actually was just published in Blood yesterday, I think. So the title is Hydroxyurea, a new old therapy for LCH. And so back in the old days, when your grandparents got CML, 75% of them were given, this is before Gleevec and before sort of this new class of drugs, hydroxyurea would keep 75% of the patients alive with controllable disease. And there's this whole family of diseases that are kind of like LCH, that there's these myeloid precursors that just kind of they drip from the faucet a little faster than they're supposed to. And they responded really well to hydroxyurea. So I don't know why Ken thought of this, but he did. He said, let's just try hydroxyurea. And it's really worked well on several of our patients. And so, whether this is going to cure like the high-risk patient, I think that's a little less likely, but what a great drug to ask the question, if you take hydroxyurea for 1 or 2 years, can that prevent neurodegeneration, for example, or can it control disease? Because it's a drug that every kid in the United States with sickle cell takes, and there's almost no toxicity associated with it. And it's oral. All right, and so there's still some stuff that we haven't quite figured out. So, this is one of these huge surprises, is we're looking at our plasma proteomics. So what this represents is about 200 kids with LCH at the time of collecting their blood. At the time of therapy, before they got any therapy, we collected their blood and we say, can we detect differences between kids who have BRAF V600E and those who don't, high risk, low risk, those kinds of questions. And there are some differences between those groups, but the biggest difference is, what this tells us is, can you tell based on just these 4 proteins who's going to relapse and who's not? And you can see there's this huge difference, and this includes both high risk and low risk. It's sort of a mixed bag of patients. But I mean, what a huge difference between 20% and 80% of kids relapsing. And so we tested it. We said, is this real or is this just a fluke of statistics? But we tested it on a second cohort and saw the same thing. And so this does 2 things. One is you can be agnostic about what these molecules are, and so you don't really care what the function is. But is this a test where you can say who needs higher therapy versus kids who don't? But then, scientifically, you say, well, what does this mean? What's happening? What's the difference biologically between these 2 cases where some are really having an inflammatory response and some aren't? So we don't know the answer to that yet. So those are papers that are either in press or close to being published. And then here, just to kind of follow up on the GWAS study, I think the significance of this GWAS study is that it shows that there is in fact some role of inheritance, probably in susceptibility to LCH. And I suspect it's not going to be so much in the susceptibility to getting LCH itself, but maybe to being able to acquire the BRAF V600E mutation. And so this may actually impact way more than just LCH, but a huge variety of tumors that are associated with that mutation. But stay tuned. This is still in development, but I think it shows that this model works, and I think the more logs we throw on the fire, the more finely we can map this, or the more data we can get out and find even more variants that could be informative. All right, so this is, I'm sorry, is there a question?
The grandparents factor into the sick bird cure.
Yeah, well, we haven't. So the way we designed the study was we did patients and their parents, because then you can say a little more directly. The way we did the study was to say, is there any gene that's inherited in a non-random fashion from the parents? Because you should get half from mom, half from dad. So if there's a gene that you get more than that more often shows up in the LCH cohort than 50-50, then it could be a risk allele. It doesn't mean that everyone who has that gene is going to get LCH, but something about that confers a little bit of risk. And so you could go back to the grandparents and see if there's some role for that, but at least just for freezer space, we haven't gone to grandparents yet. All right, and so this is, I think, a discovery that we're probably the most excited about recently. As Ken mentioned, we've been looking at neurodegenerative disease. I think this is one of the biggest problems in LCH. We don't know what causes it. People still argue, is it an autoimmune disease? Is it, how is it that someone who's cured of disease 10 years later can develop this progressive neurodegeneration? And so we did a proteomic study where we looked at the CSF of patients, the cerebral spinal fluid, and we did find some differences in osteopontin that does seem to be elevated in LCH. But what really surprised us was when we looked in the CSF, we didn't find any circulating or any BRAF V600E. So we thought, well, maybe we'd find BRAF V600E in the spinal fluid of these patients. We did in 2 cases, but those kids also had kind of active tumors in their spinal cord, so it doesn't really count. But what we did find is that in about 40% of our patients who have neurodegenerative disease, we're able to identify, I'm sorry, that's over here. We're able to identify circulating cells that carry the mutation. Now, this is kids who are supposedly cured, who don't have any active lesions. So what are they doing with these cells that have the mutation? And then, I don't have it on a photo here, but the next, we were able to get a couple biopsy samples where we did quantitative PCR on biopsy specimens from kind of this location. 7% of the cells in this patient have the BRAF V600E mutation at that site. But if you would look in the frontal cortex, 0% of the cells have that mutation. So I think what it makes me think of is a model where, Ken, next slide. Can you do the next slide? Where this isn't, perhaps this isn't a problem of local spread from having a lesion into the brain or an autoimmune disease, but could this be these sort of circulating precursors that somehow are allowed to go to the brain and turn into microglia? So microglia are the part of the brain that in some ways serve the same role as dendritic cells, where they kind of mediate immune responses. And even though they're seeded at birth from the yolk sac, they can be replaced during times of inflammation by monocytes, which are the cells that carry this mutation. So we think that neurodegeneration arises from these sort of cells that have the BRAF V600E mutation or some other MAP kinase activating mutation that then go from the blood into the brain rather than being sort of a brain intrinsic problem or a specific immune problem with the brain. And if you go back to the previous slide, Ken, I think that hypothesis is supported a little bit by some kids who have really active neurodegeneration that we've treated with BRAF inhibitor. It doesn't project very well for this, but you can see that all of this white fluff went away when on BRAF inhibitor, and this patient went from being in a wheelchair and incontinent to being able to go to school. I mean, it wasn't a complete cure, but I think it suggests there's something about that pathway that's activated. So I think, again, this study kind of reshapes our focus from just looking at the brain and sort of the risk organ, the sort of facial lesions that could be a risk disease, to saying, well, maybe the same precursor goes to the facial bones that's allowed to go to the brain rather than it being a problem with the facial lesion going to the brain. So this is something we're excited about. We're submitting for publication, and we don't have all the answers, but I think what it says is you need to collect blood and CSF on these patients and don't let these lesions kind of don't let them fester. I think they have to be treated, and there's some evidence that they respond to chemotherapy as well as to BRAF inhibition. One child who's had really bad disease for over a decade didn't have much of a response to BRAF inhibitor, and I think probably there's some point when there's enough damage done that it's difficult to have a response. So I think it shows the community needs a systematic approach to this problem, which we really lack at the moment. Okay. All right, so for BRAF, or for switching to HLH, again, this is sort of the dogma. Here's a Swedish pie chart, 13 patients with HLH in 3 years in Sweden, and they all had mutations in the sort of HLH, in the cytotoxic T cell pathway. So in Texas, and this is an early version of, we've got many more cases now, but it sort of shows you what we find, where you have this smattering where, yeah, I mean, a reasonable percentage have these mutations, but then a whole bunch don't. And what's going on with those patients? And can we do some sort of gene and outcome analysis to predict who needs therapy when, and who's high risk, who's low risk, and those kinds of questions. And another problem, getting back to coming full circle, when we started with what kind of got me into histio was that one patient where, we're sort of scratching our heads. If you're going to have chemo and she goes up in flames, we'd certainly not feel good about that. But to make people braver about when do you really need to use immune suppression versus when is that not appropriate. We have a series now. This is actually we've collaborated with Cincinnati, and now we have about 60 HLH patients and 25 or so sepsis patients. And there's a clear signature in the plasma about HLH-mediated inflammation versus sepsis. And if we can put that into clinical use, maybe we can say these are the patients that need to get immune suppression immediately versus those where you can just give supportive care and wait. All right, and then organizational support. So, how does this all work? How is this money kind of making a difference? And I would argue that none of those, maybe the ferritin would have happened without HistioCure because that was before your time, but everything else was really because of HistioCure, truly, because otherwise we wouldn't have been able to maintain the lab effort and expand what we're doing. And what we've been able to do is go from this million, now it's over $1 million from HistioCure to, I just kind of counted it, we're somewhere around $9 million of grant funding in the last 5 years. And that's also bringing in all these different organizations. And some of this is not, of course, all in our lab, but some of it is the consortium and some of our grants that we're co-PIs on. But it shows you that that's the effort of people around the world working on histio so that's a pretty good return on investment. And then our lab, we're more productive. We're also more expensive now. But if you look at the team size, it's really grown from, I think this is 2, right? This is me and Ken. And then we're up to, last time I counted, about 25, 30 people that actually directly work on histio projects in our lab. And there's a sort of an example of the grant funding. Okay, so I was asked to write the new version of this chapter last year, and so as part of writing the new chapter, I thought I'd go back and see, well, what were people saying about LCH, about histiocytosis and LCH back in 1998 when this last chapter of this book was written. And so Bob Arcisi and John Pritchard, who are sort of some of the pioneers in the field, so at the time, what were the pioneers saying? So they're saying LCH treatment strategy, their air quotes, not mine, is based on a roulette wheel rather than scientifically based logic. Certainly part of this confusion and lack of consensus is derived from ambivalence as to whether LCH is a neoplastic disorder, immunoregulatory disorder, or a disorder with characteristics of both. And I think that's really true, that all histiocytosis have suffered a bit of an identity crisis. If people don't know what it is, they don't know how to approach it, they don't know what groups to tackle it, they don't know which doctors are responsible for it. And I think that just having an identity has been a huge problem. I think parents have probably, you can tell me, have suffered from this. Like, which group do you belong to? Which clinic do you go to? What do you tell your friends when your kid has a disease? And I think that one of the challenges is I think as maybe even more than many other diseases, this is one where everyone has their own version of it. So it's not like you can look at 1,000 kids and say, 90% of them look a certain way. And I think the way that LCH manifests, and I think it's very similar to, you can have HLH be on the same spectrum, is you have some mutation somewhere along this particular pathway at some stage of development, and that's sort of each kid's personal path to LCH. So how do you approach diseases in a group of patients when it's really a sort of a personalized pathway? So with HLH, the path is this sort of homeostasis. So your dendritic cells talk to your T cells. So you're supposed to respond, but you're not supposed to respond too much. So when that balance gets thrown off, that's when you get HLH. So these new models are emerging. You can go skip that. And so I think for HLH, you have the spectrum from, if you have a perfect mutation, you can present at day 1 in the ICU. But if you or I got Ebola virus, we meet criteria for HLH. And so how do you manage the sort of spectrum of immune defects to immune activation? So I think the answer is you just say, okay, well, plug in your little reporter at the garage and it tells you which part's broken and just fix this. So that's really what we're trying to do with our patients. And I think a way to do that is also, we can't do that on the scale of just a single institution, but I think what this shows is a single group dedicated to this group with a single focus on this group of diseases is able to make observations that can then be translated. And I think technology is catching up, and the pathways that happen to be involved with these diseases are applicable to other diseases, so other groups are becoming interested. But right now, as I mentioned, there's the North American Consortium for Histiocytosis. The Histiocyte Society was the original one that everything kind of grew out of. Children's Oncology Group is getting involved. The Bone Marrow Transplant Group is getting involved. And then, Novimmune is a company investing in, finding a cure. They're trying to get FDA approval for interferon gamma drug for HLH. Plexicon is looking at BRAF. The LCH is a model of MAP kinase activation, as is Genentech. And can we test their new drugs on LCH patients as a way to prove that they work, and then they can be leveraged to apply to other cancers. So how do we solve the problem? So just improve understanding of pathogenesis, develop and test rational therapies, coming up with risk stratification. And again, this is all kind of going towards, as we do more and more trials, can we then go back and look and say, how did each patient do? So we get more and more refined risk stratification. So the idea is we're going from this just sort of make stuff up to actually testing things, right, thanks to Spit for Cure, and really going to sort of a precision approach of personalized medicine for each patient. So, are we there yet? I'd say we're not there, but we're making huge progress. And if this is the 5-year point, I think it's okay for us to sit on the top and have our beer and look around for a second and then get ready for the hike down. But I think we're on our way to moving from focus on discovery to focus on testing clinical trials. So I think I'll stop there. Okay, so here's the team. You can see we're growing. So next. Yeah, I think that's fine.